So Michelle, because QT prolongation is something that we're becoming more aware of and increasingly having to give advice about it, it'd be really great to draw on some of your experience and expertise. So can we start by talking about that classic heartbeat ECG and what we see and what it means?
Okay, so each portion of a heartbeat produces a different deflection on the ECG, and this is recorded as a series of positive and negative waves. So normally you can see up to 5 visible waveforms. So the P wave represents atrial depolarization. The Q wave shows septal depolarization. The R wave is early ventricular depolarization. Then the S wave is late ventricular depolarization. And then the T wave shows repolarization of the ventricles.
Great. So when we talk about QT prolongation, what does that look like on the ECG?
So the QT interval is the time in which the ventricles take to depolarize and repolarize. So it's therefore a measure of the ventricular action potential. So in long QT, your heart takes longer than normal to recharge between beats. So if you have a long QT, then you're more at risk of serious irregular heart rhythms, such as torsade de pointe, which can cause sudden cardiac death. It is important to note that long QT is uncommon. It's supposed to occur in 1 in 2,000 people in the general population.
Great. So in terms of getting an ECG done, we might read in the literature that you need to get a baseline ECG done. How easy is that in practice? Can anyone do it? Can it be done on any ward?
I think getting an ECG done is quite tricky. It is a challenge. On a cardiac ward, most cardiac nurses can do an ECG. We also have the cardiac technicians that can do an ECG. Outside of a cardiac ward, it might be more of a challenge. Maybe on a general medicine ward, you might have somebody that can do an ECG, but it is sometimes a challenge. Also, you need to remember that once you've got an ECG done, you need someone that's appropriately trained to interpret that ECG, and it takes quite a skill to be able to spot QT prolongation and read an ECG.
Okay, that's great. Now, what's a normal value for QT prolongation or QT interval?
Again, that's a bit of a challenge. The QT interval is heart rate dependent, and normally in the literature it's quoted as the QTC, so that's corrected for the heart rate. Normally we think that a normal QT is less than 440 milliseconds in men and less than 460 milliseconds in women. There are different methods available to calculate QTC, so it will vary slightly depending on which method you use.
So what would constitute a significant increase in the QT interval?
I think generally in the literature, a QTC of greater than 500 milliseconds is considered clinically significant, and that increases your risk of arrhythmias.
Okay, and what would sort of predispose someone to getting a QT prolongation? Are there certain risk factors that people can have?
So the main risk factors that you have are if you're female, if you're increased age, so the older you get, the increased risk of getting QT prolongation. If you have hypokalemia or hypomagnesemia, also if you have heart failure, because in heart failure you get a reduced repolarization reserve, so you're more likely to suffer these unusual arrhythmias. If you have bradycardia, if you have ischemia, congenital long QT syndrome obviously predisposes you to further arrhythmias, and also if you're obviously taking certain drugs which either have direct or indirect effects on the QT interval.
And presumably the more risk factors you have, the more at risk you are, so there's a cumulative risk.
Yes, definitely a cumulative effect. If you've got renal impairment or liver function impairment, then obviously that can affect drug metabolism and excretion, and therefore that can have additive effects on the potential to cause QT prolongation.
So if a patient experiences QT prolongation, what would they experience? What does that mean for them?
The kind of symptoms that you might experience if you have QT prolongation, you may experience new palpitations, you may have syncope or blackouts, and you may progress to a seizure. It is quite difficult because quite often you won't know that you've got long QT because it will be symptomless, but these are the potential symptoms to look out for, and if any of those occur, then the patient should seek medical advice straight away. It should be noted that long QT is the leading cause of sudden death in young, otherwise healthy people, and it's also thought to be the underlying cause of sudden infant death syndrome as well.
And there must be different ways in which drugs can kind of cause QT prolongation. What are the sort of mechanisms that you're aware of?
Okay, so there's three main mechanisms of QT prolongation caused by drug interactions. So if you use two drugs together that can both prolong the QT interval, then you get a pharmacodynamic effect, and the effects of those two drugs are additive. If you use drugs that potentiate the QT prolonging effects of other drugs, so if you use drugs that can drop your potassium, then if you also have a QT prolonging drug, then that effect will be seen worse. Also, if you use a drug that can cause bradycardia with a drug that can cause QT prolongation, then the effects become visible. Things like if you use diuretics, which reduce your potassium, and you're on a QT prolonging drug, then you might be at risk of arrhythmias. The third mechanism of drug interactions is drugs that affect the cytochrome P450 pathway. So, for instance, antibiotics like macrolides or antifungals, which inhibit cytochrome P450 enzymes, which then will affect the metabolism of QT prolonging drugs. So that's a pharmacokinetic interaction.
And so moving on to some sort of real life scenarios that pharmacists might encounter on the ward. So we might be asked to advise about the suitability of QT prolonging drugs in patients that have already got some sort of heart disease. What sort of heart pre-existing conditions would you worry about? What would ring alarm bells to you?
So I would be really careful of anybody that's got a family history of sudden death, because that could be an indicator that they have prolonged QT already. And those kind of patients would be investigated, but that would ring alarm bells to me. Also, anyone with known arrhythmias should be very careful if they take drugs which prolong the QT. I think as a general rule it is the combinations that cause concern. So if you have an elderly female patient with heart failure that's prescribed a QT prolonging drug and then an antibiotic which also causes QT prolongation, or drugs that are affecting the metabolism of those drugs, then that's when you need to worry. So it's the additive effects in someone that's at risk by multiple different mechanisms. It should be noted that some drugs such as amiodarone can cause prolonged QT very, very commonly, but it's quite rare for them to progress to torsade de pointe, the ventricular arrhythmia that can cause sudden death. So there must be other protective mechanisms occurring which we don't fully understand at the moment. As a general rule, I would suggest that you always consider the risk-benefit of the profile of the individual patient and assess the best way to manage that individual patient rather than just a blanket approach for everybody.
Should we consider a scenario where if a patient who's perhaps not admitted for a cardiac reason and they had an ECG done and then it was shown that they had a QT prolongation and the pharmacist notes that they're on several medicines that cause QT prolongation, what would be your thought processes in that sort of scenario in terms of would you hold the drug, would you dose reduce, how would you go about it?
I think that's quite a challenging situation. If you're doing an ECG, then obviously you're doing it for a reason, so it's quite likely that cardiology would be involved or at least advising on that patient. So it's important to get a cardiology review and for someone that's experienced in looking at ECGs to assess that QT prolongation and the risks that causes. It's really important to replace any potassium or magnesium levels and make sure that they are have a good plasma level so that you reduce your risk of getting any arrhythmias. And then you need to consider the risk of stopping any medicine. So it actually might be worse to stop a medicine than to carry it on. Obviously, if you can change to an alternative, then that would be the best option, but that's not always possible. So it's really just assessing the risks. It's also worth remembering that QT prolongation caused by drugs is drug dose dependent, so potentially you could reduce the dose, and it's also worth remembering that IV formulations cause the highest risk of QT prolongation. So it's giving that medicine IV seems to have an added risk than giving it orally.
That's interesting. So just to finish with, if you're talking generally to a doctor about taking drugs that might prolong the QT interval, or there might be an interaction that might prolong the QT interval, what sort of things do you take into account when you're sort of giving advice?
So I tend to think about the characteristics of the patient. So are they male or female? So obviously females are higher risk than males. How old are they? So the older the patient, the higher the risk, and what their cardiac history is. So are they known to have arrhythmias? Do they have heart failure? Do they have multiple different cardiac risks, so ischemia and heart failure, and they're at risk of arrhythmias as well? All of that to start with. Then I think about the additive effects of the drug, so either directly or indirectly. So indirectly by affecting potassium or magnesium, or affecting metabolism of other drugs. Then I need to think about whether I can use an alternative drug that doesn't prolong the QT. Often that's not possible, but there may be potential to do that, especially if you're choosing a particular antibiotic. It might be worth trying to choose one that doesn't prolong the QT or doesn't affect cytochrome P450 enzymes if possible. Then you need to think about the risk of not giving the drug. So if I didn't give this drug, what would happen to the patient? And quite often, from a cardiac perspective, it's not an option not to give the drug. So that is a challenge sometimes. If you decide to give multiple medicines, can an ECG be done prior to starting, and then also once the medicines get to steady state, to see whether there's any change in the QT interval? That's really useful to do. You should also advise the patient to report any new palpitations, any blackouts, or feeling dizzy very, very promptly, and seek medical advice straight away, because that could be a warning sign that we've prolonged the QT interval. You should also make sure that the patient's potassium and magnesium are checked, and make sure that their levels are adequate prior to starting a drug, and also continue to monitor very closely throughout the treatment. If the patient goes home from hospital, then it's also following up with GP surgeries to make sure that they're monitoring potassium and magnesium levels if possible, and replacing as necessary. It's also worth being familiar with the list of drugs that can prolong the QT, and there's various websites that are available for you to look at that. It's also, lastly, to remember that you should not use a QT prolonging drug in someone that has congenital long QT syndrome, because they're already at very high risk of progressing to ventricular arrhythmias. So that's really important to remember.
That's great. Thanks, Michelle.